Bismillahirrahmanirrahim. My name is Dr. Awais Masood. I'm endocrinologist, currently working at Doctor's Hospital. Thank you very much for having me today on this surgical symposium. Um, on one hand, these webinars give you convenience of being at home and be able to participate. On the other hand, you miss that physical part. Your interaction with your colleagues and ability and opportunity to see your friends. So without further ado, let me get started because I'm given limited time slots of only 20 minutes and I'll try to go over with you without being feeling rushed. I do not have any disclosures. So the top talk today I have divided into three parts. One is the basic clinical approach when you see a patient with thyroid nodule. The second part will go over with basic thyroid ultrasonography and the advanced thyroid ultrasonography. So when you see a patient with a thyroid nodule, what you do send them to radiology to do FNSC? No, obviously you do take a good history, do a physical examination, and in a few moments I will go over with you the importance of physical examination. So in that case, we'll highlight that if you go on a wrong track, it will have a long-term consequences. So this is a nice algorithm. All of the medical students, residents, fellows, I like them to keep this in mind, that when you have initial evaluation, when you pick a thyroid nodule on physical examination, or these days we are finding them incidentally if they go for, suppose, a carotid ultrasound or a CT of the neck, someone picks it up. What should be your next step? Your next step should be to find out if it is a functional or non-functional nodule. And how we do that? We check TSH. If TSH is elevated, showing that patient is hypothyroid, then you do an ultrasound. Obviously, you do ultrasound and TSH both. Ultrasound then put things together. On ultrasound, that shows that this nodule is not a high risk. It's basically a fluid-filled cyst. Then you leave it alone and just sometimes you don't even need to monitor them. And or if ultrasound criteria shows that it should undergo FNSC, and we will talk about what are those ultrasound criteria, then obviously you perform an FNSC. On the other hand, if TSH is suppressed, that it is a functional nodule, you look at the functionality, it's subclinical disease, you can just observe that or treat it. If it is overt hyperthyroidism, obviously you will treat. And now one other clinical points I'd like to make, that subclinical hyperthyroidism in elderly, you should treat them aggressively. Otherwise, what's going to happen? They're going to have osteoporosis. Are at risk for atrial fibrillation. So, and this is a question for residents and the house staff. What is the normal TSH in an 80-year-old patient? The normal TSH in 80-year-old person is 8. So if you are seeing a TSH of 0.8 in an 80-year-old, this is very abnormal, and that should be treated. Otherwise, that poor patient can have consequences such as atrial fibrillation. So now I'm going to present that clinical case I was pointing to. This is a patient, symptoms of hyperthyroidism, exam left level 3, lymph node, and the labs that you sent is consistent with Graves' disease. So what would be your next step? Would you send that patient for a radioiodine ablation? You will do a neck ultrasound, you will start him with thiamazole, or you send him to surgery. So obviously you need to do neck and ultrasound. You're picking up a very abnormal looking lymph node on examination and in the context of the Graves' disease. So this is a classic hypoechoic Graves gland and with increased vascularity. What we are looking at here is a very abnormal looking lymph node, and shortly I'll go over on the lymph node characteristics. Basically, it does not have hilum, maybe a small microcalcification in this lymph node, and the shape of it being taller than wider is also suspicious. So what is your next step? You do and these are the finding of that the lymph node So based on this data, what would you do next? What is your your diagnosis? Is this just the Graves' disease? We already know about that. This is not the case. Thyroid lymphoma. Thyroid lymphoma I've seen in these patients, some with HIV, rapid enlargement of their thyroid mass. They do not come in with this type of lymph node. Thyroid cancer, definitely we were looking, there is a possibility given in the context. And Graves' disease concomitant thyroid cancer, yes, that is obviously is the answer. So we do FNSE, which reveals papillary thyroid cancer. Patient is given methimazole rendered euthyroid, and then they underwent total thyroidectomy, which showed papillary thyroid cancer and several cervical lymph nodes involvement. So the point I really want to take a pause and wanted to make, suppose in the same patient, we didn't have the examination of that lymph node, and we from the labs, we know it is a Graves' disease. And what we like to, as an endocrinologist or even general practitioner, oh, it's a Graves' disease. We give them some time, make them euthyroid, and sometime we decide for ablation. So if patient goes for radioactive iodine ablation, then that particular thyroid cancer, which is sitting in his lymph node, is missed. And then obviously sometime later that patient will present with metastatic disease. So again, I cannot highlight or emphasize enough on your physical examination, history taking, risk factor for thyroid cancer, radiation, familial thyroid cancers. Look at all those risk factors before you order an imaging, because once you set up on a wrong track, then it can have lifelong consequences for the patient. Now, switching gears, we are going over the thyroid ultrasound, how it is done. Patient positioning is very important. Neck hyperextended as shown in this picture. You have your linear probe, put on gel. These are the small, minute details which all of you know. And the important point here is, in order to appreciate any abnormality, you need to know the normal anatomy. These are the, we talk about transverse images. Transverse images give you AP view, and then we work in the sagittal view, which is this one, the green sagittal view. So basically, this is a transverse ultrasound of the neck, and this is a cross section of the neck. You have this your in the middle. This is your I'm talking about on the anatomy, not the radiographic images. You have your thyroid sitting in front of the trachea. You have your strap muscles. This is sternocleidomyocyte. This is your vascular bundle, carotid artery, and IJ. So on imaging, you similar thing, right thyroid lobe, left thyroid lobe. This is trachea. This is isthmus. These are your strap muscles on both sides. This is your carotid, and then this is your sternocleidomyocyte over here, and this is your IJ. So this image is very important. Now that was transverse, and this is a longitudinal images. This is a beautiful thyroid gland, the superior, the inferior, and as you go medially, you start to see the carotids. So how prevalence is thyroid ultrasound? This slide published in this paper published in NEJM back in 1993 shows that as we age, we do develop thyroid nodules, and those are sometimes due to underlying autoimmunity, Graves' disease, Hashi glands. They end up developing thyroid nodules. So you can see around mid-30s to 60s on palpation, little under 10%, and excuse me, on ultrasonography, you can see at around 80s, 90s, you can have 50 to 60% of the patients with thyroid nodules. So they are quite prevalent. And how about palpable nodules versus on the ultrasound? We'll see a slide shortly. And the reason is obvious. If it is a posteriorly sitting thyroid nodule, it will be apparent only on ultrasound. Even a best examiner will not be able to pick up as compared to an interiorly sitting obvious thyroid nodule, which can be easily palpable. And these are some other examples, some are posteriorly, and this one is pseudonodule which is sitting anteriorly and can be easily palpated. So how many upon palpation, what are the percentages of the thyroid nodules that are missing? It depends on their size. Less than 1 centimeter, 93% are missed. 1 to 2 centimeter, half of them are missed on palpation. Over 2 centimeter, 42% of them are missed. So about 50% of the thyroid nodules are missed. Now, switching gears, this is important for you guys to learn, especially for the house staff. What are the characteristics of a suspicious thyroid nodules? You remember we talked about the algorithm, and that comes down when you decide FNC, that all this information goes into that decision making. So echogenicity, calcification margins, and halo vascularity, these are the features that we look. What are the calcification and how you differentiate it from comic tail. So calcification, there is no posterior shadowing. This is a cystic nodule which has colloid and with classic comic tail artifact. These are punctate calcification. The presence of calcification indicate your high risk for a malignancy. What are the sonographically benign appearing nodules? Sonographically benign appearing nodules are well defined. They have clear margins. They're isoechoic. What does isoechoic mean? Meaning that the echogenicity or the brightness is similar to the surrounding tissue, and then their vascularity is mainly peripheral. So this is another peripheral vascularity nodule with peripheral vascularity. Spongiform nodules are also benign in most cases, and they have clear margins. There is cystic degeneration inside going on, leading to these small cyst sponge-like formation. These are usually benign. What is the Graves gland? Graves gland is like inferno we saw in the first case that I talked about briefly. Here there is markedly increased vascularity and overall hypoechoic appearance on ultrasound, and they are benign, obviously, unless in the case that we saw. So now, what are the features of a suspicious appearing thyroid nodule? So look at this nodule. It is hypoechoic, which is meaning that it's darker than the surrounding tissue. And then if you look at, there is infiltration and irregular margins going on along this side. Again, similar hypoechoic looking nodule with irregular margins. This is another hypoechoic nodule, irregular margin with calcification, very high suspicious appearing. Similar hypoechoic nodule, internal calcification. This is a complex cyst solid, and this the very vascular solid component, more vascular it is, more suspicious it is for underlying malignancy. So this is an important slide, just making an academic point that if our ultrasound give us so much information about a particular nodule being just benign or malignant, why don't we pick it as a gold standard test to rule in and rule out? To rule in, so remember, for diagnostic tests, you need to have a very sensitive, you need to pick a test which has great sensitivity. So in case of ultrasound, the sensitivity to diagnose cancer is low, specificity is high. For FNA, sensitivity is very high, 92% versus 80%, 84%. So obviously we pick FNA when we are seeing a suspicious nodule. We do not just look at the ultrasound and say that, okay, this is benign and this is a malignant, although in some, obviously in spongiform nodules and purely cystic nodules, and that is the role of ultrasound. When there is a question, intermediate or high suspicion, we go ahead and do FNSE. So again, thyroid risk stratification, purely cystic, spongiform, mixed cyst, solid, hypoechoic, microcalcification. As you find these features such as abnormal cervical lymph nodes, your suspicious becomes increased and the FNSE is indicated. Like in purely cystic, there is no need for performing FNSE. So this is another slide showing how we decide in subjecting these thyroid nodule to FNSC versus no. So this is another very important slide. I remember when I was in training, we used to have this along in our ultrasound room, and was very helpful. So there is risk for malignancy going up, and then the percentages for ultrasonographic features of these nodules. These are high suspicious, where suspicion is 70 to 90% in those cases. So if you look at this, there are calcification, first nodule that we're looking at, calcification and irregular margin. And along this first line, you see all these features: irregular margins, hypoechoic, calcifications. And this last image is actually showing, this is the nodule, this is the carotid, and this is the lymph node, a very abnormal appearing lymph node. So very high suspicion just based on ultrasound being 70 to 90%. Yes, you do like to do FNSE in these patients. Intermediate suspicion, you can see that they are hypoechoic, but the margins are clear in these both examples. Low suspicion, this is hyperechoic. Hyperechoic is also called white knight. Traditionally, these are considered sign of a benign isoechoic. The other two, these are the complex nodules with the solid component. Again, you put a Doppler on the solid component, say if it is vascular or not. If it is vascular, then suspicion is more as compared to these low suspicion nodules. And the very low suspicion nodules are your spongiform nodule, and benign are purely cystic nodules. So what is the size criteria? Again, this is a good academic questions, but beyond academics, if they're high suspicion, even 1 centimeter, you should do an FNSE. For intermediate to high suspicion, 1 centimeter. For low suspicion, 1.5 centimeter is the criteria. They should be at least that size to subject them to FNSE. And for low suspicion, this says 2 centimeter, but I really don't subject spongiform nodule to FNSE unless there are certain other features which are making me worried, such as abnormal looking lymph node. In that case, I'll go after that lymph node rather than doing FNSE on this spongiform nodule. And obviously cystic, there is no need for FNSE. So there are just few minutes left, and we're going to go over quickly through the advanced thyroid ultrasound. Advanced thyroid ultrasound, how we do FNSE, what are the lymph node characteristics, and how we do parathyroid ultrasound. Thyroid ultrasound risk stratification, we already talked about it. We already know about that, what are more suspicious and what are the sizes that we indicate the need for FNSE. Again, these are the indication for ultrasound guided FNSE. Nowadays, we prefer doing ultrasound guided FNSE. Reason behind is this one. So this is a posterior nodule. It's palpable, but it is located posteriorly. You would not know where your tip of the needle is. You may be sampling this part, but when you have ultrasound, you know where your needle is. So I've been trained on doing ultrasound guided FNSE. I think that is better. There are experts who may be very good at doing just the palpation method, but because of this reason and because where the nodule is, you have to pick ultrasound guided FNSE where it is possible. So, and again, this is another example. So in this is a suspicious appearing cystic solid complex nodule, a sagittal view. You see that where that yellow arrow is, that is the area where you want to go. And if you're doing a blind FNSE, you would not know where the tip of needle is and where you need to get. This is basically two techniques, parallel technique versus perpendicular technique. I use both. In the parallel technique, you can see all the needle across, and you can, in a very small nodule or tricky nodule, I use this one. Otherwise, the bigger nodules, perpendicular technique works very well. So I'm gonna, with apologies to my friend, and those the organizer, gonna quickly go through the remaining slides. Lymph node metastasis, their diagnosis are present, 42%, and 21% of patients present with macroscopic lymph node mets diagnosis. So what are the normal cervical lymph node? This is an example of normal, very beautiful oval. And this is the fatty hilum that you look for in a normal ultrasound. Another normal lymph node. So this is an abnormal appearing where there is not a fatty hilum as compared to over here in abnormal looking lymph node. So we know about the lymph nodes quickly over parathyroid ultrasound. So I like doing ultrasound for parathyroid localization in addition to system EB scan for two reasons. One, if looking for thyroid nodules, if there are thyroid nodule present and going after a parathyroid anyway, then you need to know about what to do with that, do an FNC, and it will change your decision making capacity if you have more information before going after a parathyroidectomy. You really need to know if there are any suspicious thyroid nodule as well. So parathyroid are hypoechoic, and this is in the transverse view, located posteriorly. They can be superior or inferior along the border of the thyroid gland. And this is again in the transverse view located posteriorly, and then this is sagittal view. They can be superior or inferior. And this is again another image of superior parathyroid, hypoechoic, round, and located along the border of the in the sagittal view again. And this is an inferior. The one big characteristics when you localize it, you put on the color Doppler, you can see beautiful polar artery feeding this parathyroid adenoma. So these are the parathyroid ultrasound characteristics that we already talked about. In summary, the take-home points that I want all the house staff to remember again, these are the 3 points: history, physical examination, as highlighted by this case of Graves' disease with had a metastatic lymph node. And the second point is, remember this algorithm when we are deciding, and try to look for, I've seen so many thyroid uptake and scan in euthyroid patient. TSH is normal and you're getting uptake scan. Follow this algorithm when you're ordering a test. It will try to, when trying to see if it is a functional versus non-functional nodule. TSH is normal, no need for ordering a thyroid uptake and scan from a nuclear medicine friends. And in the last, remember this ultrasound features when you are sending a patient, and what size of the your thyroid nodule should be when you are subjecting them to FNC. Again, with the experience, you will learn more that spongiform guidelines are guidelines, but use your clinical judgment. Many thanks, and I'm gonna miss you all. See you all next year, hopefully in presence after this COVID is over. And I apologize for going over my time. Thank you, and have a nice day. Bye.